everybody. My name is Kat Mallett. I'm a nurse practitioner at Children's Mercy in Kansas City in the end-stage kidney disease program. And I'm really happy to have this privilege to help families get some clarity on dialysis modalities and how they can be used as a bridge to transplant. So again, thank you for this opportunity. I love making sure our families know what their options are. So just a brief overview of what we're going to talk about today. There are a lot of things we could cover. Each kind of could have their own talk. So we'll breeze through some of these, but the objectives are just to give you some high-level information so you can have better conversations with your transplant and end-stage kidney disease team. So we'll just briefly go over kidney function basics. We'll talk about those pre-transplant treatment modalities, primarily dialysis. We're going to highlight some key factors for transplant eligibility and timelines and review some special considerations. So what do your kidneys do? Most people know that kidneys clean blood and they can help make pee by controlling how much fluid stays in your body and how much leaves. But what a lot of people don't always understand is that they help control blood pressure. A couple of ways they do that is through some hormonal influences and managing that fluid balance in the body. They also help make red blood cells, which carry oxygen to all the tissues in our body, all those cells. And so that's also done through a different hormonal influence. They help keep bones healthy by managing a somewhat complicated calcium, phosphorus, and parathyroid hormone relationship, and the impact that those have on not only our bones, but blood vessels. And the kidneys help kids grow. We have inherent growth hormone, but there's something about the way our kidneys don't function well that can impact the way our body uses growth hormone. So the kidneys don't produce that hormone, but they do impact how the body's able to use it. And it's really important to understand what the kidneys do, because when they're not working and they're not healthy, a lot of things start to make sense. And this is a slide that I often share with families, and parents, especially, or caregivers will say, oh, this is my aha moment. This is all making sense on why my child wasn't feeling well over the last several months or even years. So knowing that kidneys produce pee and help manage that fluid balance, if they're not working well, then kids might start peeing less or eventually not at all. And that fluid has to go somewhere if it's not leaving the body. So you'll start seeing some puffiness in sometimes the hands, the feet, the face, and sometimes it kind of hides elsewhere in their body and it's not as obvious. Again, with that fluid management, blood pressure can be high. And as I mentioned, those hormones sometimes don't behave like they're supposed to when the kidneys are not healthy. Kids can also feel tired. Again, a lot of that is because of the lack of red blood cells, so anemia, and the way the kidneys are not helping to produce that hormone called epoetin. And additionally, the waste product buildup that can occur when they're not filtering out those waste products. Along with that waste product buildup, kids sometimes lose their appetite. They don't eat as well as they used to, and that can kind of come in phases. So sometimes they'll eat pretty good, and then sometimes they don't feel like eating as much. And along with that comes some nausea and just kind of general not feeling great in their stomach. And then growing slower than other kids. Again, that hormonal influence that the kidneys don't allow the body to use growth hormone quite like it should, and the bone management that the kidneys have a role in. And itchy skin, which is, again, a buildup of waste products. And all of these things can be a little more obvious in older kids, but in infants, it can be really hard to know. So a lot of these things may just present as fussiness that you can't really put your finger on. This is a really great image from the National Kidney Foundation that we use in our education here at Children's Mercy. I think it's always important to kind of visualize what we're talking about when we're describing GFR, or glomerular filtration rate. That's just another way of saying what the kidney function is. So as you can see, we have really almost 6 stages, but 5 is what you're going to hear people saying and referring to the most. And so stage 1 is where there might be some kidney damage signs. So there might be protein in the urine, but overall the kidney function is normal. So kind of like a test score, right? 90 to 100%. Things are still going pretty well. And it's going to be hard to notice any of those signs and symptoms I just mentioned. And as you move down and you see that as kidney disease progresses, there's less and less function of the kidneys. And so somewhere around stage 4, that's when transplant workup usually begins, ideally, especially if we already know what the underlying kidney disease is. And that can vary depending on the presentation will vary depending on that underlying disease. So some kids are born with it, we know pretty early on. Some kids aren't going to know until they're maybe in their adolescent years. And these kids sometimes, what we say, fall out of the sky into the ER because finally over time their body has stopped being able to compensate and they've reached a tipping point with their kidney function and they feel very bad, have high blood pressure, unknown anemia, just extra fatigue, and they end up in our ER. And that's when they get diagnosed. So, you know, if we know about it ahead of time, we try to be more proactive, and sometimes that can't happen. And then stage 5, so somewhere around 15-ish%, give or take, we start talking about the need for dialysis as it pertains to getting them through to transplant. So some of this too can be, you know, it's not hard and fast just because someone's GFR is maybe 13 or 14. If they're otherwise functioning decently and we can get them to transplant without dialysis, great. And we can medically manage them with other supplements and diet and things like that. That's not an absolute, oh, their GFR is less than 15%. We need to get them on dialysis. So it's always a conversation really with your healthcare team. So what is ESKD? That just is an acronym for end-stage kidney disease, also called kidney failure, because as that prior graphic demonstrated, you've got around 15% of remaining kidney function. So this is formally diagnosed after 3 months of those signs that have been presenting, and we see that the kidneys aren't going to recover without dialysis or transplant. And it really just means that those kidneys aren't working well enough to keep them feeling healthy. So that's why we have to talk about these modalities. I will say kids that have progressed to this point, especially if it's been pretty gradual, that's their new normal. And once we get them on dialysis, a lot of times they didn't realize how bad they had been feeling until we're able to help them with that modality. So. And we'll talk more about that here in the upcoming slides. So is there a cure for end-stage kidney disease? Unfortunately, there is not a cure, but we do have these treatments, kidney transplant being the gold standard, of course, and then dialysis. And we'll talk about hemodialysis and peritoneal dialysis. Just going to reinforce dialysis is a treatment for kidney failure, as is kidney transplant, and there's not a cure. But dialysis helps to kind of make up as much as we can for that kidney function. It can't completely replace it, but it does help us get the blood cleaned as much as possible to get those waste products out and get the extra fluid off their body. Again, we'll talk about PD and hemo. And it's important to know that dialysis start time counts towards transplant points if your child is on the deceased donor list. So we'll start with peritoneal dialysis. This is a treatment for kidney failure that uses the lining of your peritoneal cavity or your abdomen. So it uses that inside your body to clean the blood. And we're able to do this 7 nights per week at home. And we need to have a dialysis catheter to get this performed. I should also mention I do have some medical diagrams and some pictures. So that was probably the worst time to bring that up, but there will be some other ones coming up as well. So if you're squeamish, just want to warn you about that. But I think it's important, and we've gotten a lot of feedback from families that they appreciate being able to see these visuals so they have a better handle of what is coming down the road when we talk about dialysis. So this catheter is just a really soft tube. You can see it's bendy, and it's put into that peritoneal cavity by a surgeon. And we use that to connect to their dialysis treatment. So there's a sterile bag of fluid here that gets connected each night to that catheter. And it fills up this cavity here so that we touch as much of this lining that goes all the way around as possible. And that we work that up over time, especially for anyone who's brand new to peritoneal dialysis. But that way, when that fluid is touching as much of that lining as possible, we get the best filtration, so we can get all those waste products out and the extra fluid. And we design a prescription for that fluid to stay in the body for prescribed amount of time, let's say an hour, and then it drains out through this drain line. So kind of the clean fluid goes in, pulls in all those toxins and waste products and extra fluid, and then we drain it out. And that happens over several cycles each night. In our program, and most programs that I'm aware of across the United States, we have to do a home visit prior to starting PD. We have to make sure that the environment is safe because this is something that's being performed every night at home. So we want to make sure that our families are equipped to do this to lower the risk for any complications. Usually this is done at night while the kids are sleeping, so it does allow them to get to school. Travel is possible, it just takes a lot of planning and communication with the team, but it is possible, easier to do than with hemo. You'll need a clean indoor space to store supplies, and I have some pictures of what that looks like coming up. It is important to know there's a risk for peritonitis. So this is an infection of that lining, and kids can get pretty sick with peritonitis. So, you know, we take it very seriously when we're training, and that's one reason we have 2 trained caregivers that can do this at home. You know, we have some single parents that obviously could still do this. We just need to make sure they have a good support system and somebody that can come help them that can be trained and do it regularly. So there's no, we want them to stay proficient enough so that there are no mistakes. And that training usually takes about 7 to 10 working days. This is a picture that tends to surprise a lot of people, but this is just a few examples of what it looks like to store supplies in your home for peritoneal dialysis. So on the left, you'll see all these boxes of different peritoneal fluid. This is probably close to a 1-month supply with also some reserve bags as well. But we do need it to be a clean, dry space, no wet, musty basements, no outside duct closets or anything like that, because it would compromise the constitution of that fluid and could really create some complications. Here on the right, you'll see this is how one family had their PD machine set up. This is the machine up here on the top rack. And then you can see there's all this tubing, supplies for dressing changes, hand sanitizer, masks, disinfecting wipes, things like that. So that's how they chose to set theirs up. And then here in the middle is an infant who's getting home dialysis. And this is the machine with one of those sterile bags of PD fluid on top of the heater that warms that fluid, is connected to the child, fills up his or her belly for a prescribed amount of time. And then they have it draining down here into a bag that's in a tub. And again, that happens over several cycles overnight. This child also happens to be on formula, so they're receiving that at the same time. Some special considerations, really not allowed to swim or take a tub bath with that catheter because we don't want anything being submerged due to the risk of infection. Again, these kids get very sick with peritonitis if there is an infection. And every time that peritoneum gets infected, it can create scarring, which can, over time, make it harder for PD to be adequate. So we always want to try to avoid that. You should always talk to your team about what this looks like for you, but certainly at our program, we don't allow swimming or tub baths. Doesn't mean they don't get to get clean, but we just work with families on how to work around the hygiene. Nice thing is, especially for some of our older teenagers and older school age kids, that catheter can be hidden under clothes, so they appreciate that. Daily dressing changes are needed for that exit site to keep it clean and dry and to keep an eye on it, because there's an exit site infection where that catheter comes out of the body that can travel through the tunnel and into the peritoneum. So we do take that seriously. And depending on the situation, you may have to do hemodialysis while that PD catheter heals and as the PD prescription is being optimized. So what is hemodialysis? Again, it's another treatment for kidney failure, but this time it cleans blood outside of the body, and there will be some other pictures coming up in the next couple of slides, just heads up. But this one is done usually 3 to 4 days per week for about 3 to 4 hours per session. Some scenarios, patients might only need 2 days a week, but that's definitely a conversation to have with your team. For us, it tends to be our psychosocial situations where maybe somebody lives far away. They need some dialysis, but we can't get it arranged at a local hemodialysis unit, or they're just a little too young for an adult unit. So again, those are special considerations to bring up with your team. And sometimes it's performed more than 4 days a week. So younger kids who aren't PD candidates or other unique diagnoses that require extra dialysis. So 3 to 4 days is about the average, but in some circumstances it can be less or more. Every dialysis needs an access, so we have to be able to get that blood from the body to the machine to where it's cleaned and then back to the child. So this picture's a little blurry, but this is basically the filter where all that exchange happens. This is a blood pump that kind of spins the blood and pushes it into that filter. And then once that has gone through the filter, clean blood is then returned back to the patient. There are 3 kinds of access, but I'm really going to focus more on the hemodialysis catheter and the arteriovenous fistula. You'll sometimes see it referred to as AVF, or mostly we just call it fistula. Grafts do exist, but those are for more unique situations. And I think in my 11 years here at Children's Mercy, I've had 1 patient that used a graft. So in our limited time, I want to focus more on these other 2. All right, pictures that might upset some people, but a hemodialysis catheter is a small soft tube that is inserted into this internal jugular vein and goes into the top chamber of the heart. And this is what it looks like basically on the outside. Again, just another medical drawing from an artist, but this is much more what that looks like when the dressing's not on it. And then the tubing is connected to these 2 little hubs that helps get that blood out of the body to the machine and then returned back to the patient. Hemodialysis catheters can be used right away. This is an example of one of the dressings that we do here in our program. But as you saw, that goes directly into the top chamber of the heart. So again, we're always wanting to prevent infections. So showering and swimming is a no-no with this as well. In some adult units, so if you have adult family members who have been on dialysis, they treat their catheters much differently than we do in the pediatric world. So you should expect that your pediatric dialysis program is more than likely going to say no showering or swimming. For us, because we use this bio patch, this is good for a week. So we change our dressings once a week. But every so often, we have to change that more frequently, especially if there's irritation or some early signs that maybe that area is getting infected. But the weekly dressings are nice because that means we don't have to get into that area more often than we need to. Every time you do, that's an increased risk for infection. And the other times we would change that more frequently is if the edges were peeling up here and there was an opening past this gauze. So that had all peeled up before it was time for the next dressing change, because that's a good way for bacteria to get in there and create an infection. We don't want to do that. Again, if this is a central line associated bloodstream infection, you might hear people say CLABSI. Kids can get pretty sick with this as well. So I'm painting a picture that sounds a little scary, but I gotta say, we do a really good job protecting all of these accesses. And a lot of that comes down to the cooperation with the family and clear communication, letting us know early when something has maybe not gone perfectly with dressing changes or with the dressing staying intact. When this kind of access, you don't need needles. Again, like I said, they just kind of screw onto the lines, screw onto those little hubs. When we talk about fistulas, this is basically created under the skin. This top picture is an example, but it is a special surgeon creates a connection between the artery, which is high pressure, connecting it to the vein, which is typically lower pressure. But over several weeks, it helps plump that vein up in a way that we can use it to access the patient's blood so it can get cleaned outside with the machine. But we do use needles for that. They're blunt needles, which again, we kind of work up in a certain way to get to that point. But you can see in this top picture, we use buttonholes. So it actually ends up creating a little bit of a tract, much like an earring hole. So over time, patients don't even really feel that. And in some of our older kids, they actually have learned how to access themselves. So, because they prefer to have that control. So that's one benefit to that. The fistula is the best access for long-term treatment. So if we think someone is going to be on dialysis for longer than a year, which of course no one has a crystal ball, but if things are kind of preventing us from getting to that point, then and they're old enough, we might start talking about a fistula. As I mentioned, it takes about 3 months or several weeks at least to be ready to use. It can last for years, has a very low risk for infection, and you can shower and swim with a fistula. So a lot of our older kids and young adults prefer this once they finally get it created. There's no dressing changes, but not everyone can have a fistula. And the difficult thing is that in a lot of pediatric programs, even if we have all the resources available to us for everything else related to end-stage kidney disease, there's a scarcity of vascular surgeons out there that perform these well on smaller patients. So it tends to be more of our older grade school and adolescents, young adults who are candidates for this. And it also depends on their vasculature, so all their blood vessels. So if they've had a long history of clots and things like that or narrowing, they may not be a good candidate. So they have to be evaluated for that by the surgeon to determine if they're a good candidate or not. And like I said, one of the complications can be that the fistula can clot or narrow. And so it's probably preferred in a lot of cases, but it doesn't come without risks. And since it takes a few weeks to be ready to use, it's not uncommon that patients have to be using that hemodialysis catheter to receive their treatments while the fistula heals. When we talk about social work assistance, like I said, some kids have had their chronic kidney disease for quite some time, and it has just gradually progressed to end stage. Some have a brand new diagnosis seemingly out of the blue, and there's a lot of adjustment. So either way, our social workers really help us a lot with mental health and well-being, and helping our patients cope with life events and this, new normal while they're getting ready for transplant. So our social workers do a great job making referrals for counseling, which mental health is still a really important part of our overall health, and even more so for our patients who have chronic illnesses. And in all these transition periods along the transplant journey, it's really important to, know that that option is available. They can also help with lodging and transportation. So, where we are, we have a Ronald McDonald House, and we've partnered with some hotels, can be especially important if our patients are coming for in-center hemodialysis and there's bad snowstorm coming, things like that. So they're able to work with us to make sure our patients can get here safely, have a place to stay so they can get their treatments and get home safely. And then school, obviously, especially if they're on hemo, there might be school absences. It can be difficult for kids to keep up with their grades. And so we have a hospital-based school teacher that can help with that. But all these things related to school, our social workers can help. And of course, insurance, Medicare, Medicaid, Affordable Care Act, and employees-based insurance. Talk very briefly about Medicare coming up, but I am definitely not a social worker, and even our social workers, sometimes this can get really complicated to keep straight. So I'll hit some high levels. And then resources and referrals. Obviously, they can help connect people with community resources to help with utilities, food, any out-of-pocket medical costs, and then connecting to community groups like transplant families. So Social Security income, or SSI, most people have at least heard of this, but it's a national government program that helps with medical costs, and children that have chronic kidney disease or end-stage kidney disease are eligible based on kidney function labs. And the benefits are dependent on household income, but this could help offset costs for Medicaid if you are eligible. Again, this is just something to be aware of so you can have meaningful conversations with your social worker. Okay, the next couple of slides are about Medicare. And my disclaimer is that I take care of a lot of the clinical stuff, and our social workers help us try to keep this all straight. But basically, there are 3 parts to Medicare. A, which is free and covers most of the cost of the inpatient admissions after deductible has been met. Part B is based on income. There is a deductible, and it covers a lot of the outpatient costs, but not everything. It can help cover immunosuppression medications after transplant with a few caveats. And then Part D, I always think D for drugs. This is private companies have Medicare D programs to help cover prescribed drugs that are not specific for immunosuppression, but there are some premiums and out-of-pocket costs. Talk to your social workers about what's the best coverage plan for you, but it is important to note that some employers require you to, even if you have employee-based health insurance, if you're eligible for Medicare, some employers will require you to sign up for that anyway. So it's important to have that conversation with your social worker. And then this table on the right, I'm going to just bring up kind of the first 3 rows here. So Medicare coverage starts for hemodialysis patients after 3 months of getting dialysis in a Medicare covered facility. So essentially, if you'll remember, I said we diagnose end-stage kidney disease after 3 months of evidence that the kidneys aren't going to recover without dialysis or transplant. And so Medicare kind of uses that timeline to say, okay, on the 4th month, we'll start covering. So again, this can get really complicated. Please talk to your social worker about all the ins and outs, but generally that's how that works for hemo. For PD, since it's home dialysis, you can get Medicare coverage starting that 1st month of when the training starts, even if you haven't gotten home completely with the PD prescription and plan. And then the first day of the month coverage begins when you get a kidney transplant. Like I said, Medicare will pay first unless you have a job-based health plan. And this is again, just a reminder that some commercial plans require you to enroll if you're eligible. But Medicaid always pays last, so if you're eligible for both, that is something to know about. And then you will get Medicare coverage for the first 3 years or 36 months after a kidney transplant. If there is another coexisting disability besides the kidney failure, then it might cover you longer. But this is one diagnosis in children. So being an end-stage kidney disease patient makes you eligible for Medicare. We're all used to this being more of an older person coverage, but it does cover children with end-stage kidney disease. And then there's some helpful resources here on the right that our social workers give our families. We talked about the fact that kids sometimes have to miss school or their ability to attend school is limited. And our social workers here at Children's Mercy have a couple of great kind of 4-page letters that they send to the schools to help the teachers and the administrators and the healthcare staff there understand what the special needs are for that child. And it's a lot very tailored for that kiddo. But this is a really good kind of overview that one of our school-based teachers, our hospital-based school teachers developed a few years ago to hand out to the schools as well. So it just helps everybody understand, like, hey, because of their end-stage kidney disease and the fact that they're on dialysis, their attention span might be different. They might have slower processing speeds. They need extra help with learning. They're dealing with depression, anxiety, blood pressure issues. They have trouble sleeping at night. So all of these things can impact their ability to be successful in school. And so it's been really well received by our local school systems. And we oftentimes will have a very, like a remote meeting with school administrators and teachers too, because having a kid in your classroom or in your school system that has a catheter either in their abdomen or in their chest can be really intimidating for some. And so we're always here to support the schools too. So as we talk about transitioning to transplant, you should expect that if your kid does require dialysis, there will still be an evaluation and education provided by the multidisciplinary team, and that process varies by program. But you can see it's the Trivial Pursuit picture, I call it, but there's a lot of people involved, making sure that kids are ready for transplant and that their journey through dialysis, if required, is as smooth as possible. So it definitely takes a village, and all of these people are collaborating, of course, with you, the family. During that evaluation, you should also be told about the SRTR data, which is the Scientific Registry of Transplant Recipients. And so you can really just Google that. I have it on a resource slide too, but you're able to go in and compare transplant programs for pediatrics and then by solid organ, whether it's kidney, liver, multi-organ, things like that. So, and then through that process, a candidate has to be approved medically, surgically, and psychosocially. So we want to make sure everything is in place for the best outcome with that kidney transplant. And sometimes we have to do dialysis while we're getting through that process. I always tell people dialysis is not, the bad guy. It's truly a bridge that sometimes we have to cross to get someone safely over to transplant. So you can live a healthy life with just one kidney. It's one reason we're able to have living donors. And on average, a kidney transplant lasts about 15 years. But before I came over to do this talk, I actually saw a patient who has had his for 21 years. So again, the average is 15. You will need more than, or your child would need more than one transplant in their lifetime. and medications have to be taken as long as that kidney is working. And sometimes after a transplant has kind of met the end of its longevity, we either talk again about preemptive transplant or again, revisiting dialysis as a bridge to that next kidney transplant. That can be a little difficult for some of our adolescents who had dialysis when they were babies or 2 years old, 3 years old, and they don't really remember that, but their parents do. So having that conversation and kind of helping them understand what that looks like can be a little challenging because they don't have that same frame of reference that their parents do. And then barriers to transplant would be alcohol or drug abuse, obviously, history of not following medical instructions. So making sure you're getting to all your dialysis treatments and clinics on time, or at least clearly communicating if there's a reason why you can't make it, so we can make sure we modify, like, well, you need to come in tomorrow. Your child definitely needs to have 3 days of dialysis. We can't go too many days without it. Let's figure out how to get you in here. Not having a support system at home. Again, everyone's support system looks different. We're not saying it has to be a two-parent family or anything like that, but we do want to make sure that you have some resources for support to help you get through this transition. Insurance is very important, and then unstable medical conditions, which honestly can be a delay that people don't expect as we are trying to get people to transplant, and another reason why dialysis might be necessary. These are some other educational resources. Again, Transplant Families has a wonderful website and is providing this education for everyone. The Scientific Registry of Transplant Recipients, National Kidney Foundation has some great stuff specifically for youth, like some educational videos, things like that are interactive for the kids. And then American Society of Transplantation has a kids booklet. And I understand that there will be some other more specific talks related to chronic kidney disease and financial considerations, because again, I hit the pretty high level stuff and there's so much more to know. So I'm glad that you will have the opportunity to learn more about those things as well. And thank you so much for allowing me to be here to share this information with you. I hope you found it helpful. Thank you.